Hello everyone. Today we are going to discuss about the temporomandibular joint. It is one of the main joint which we can found in our face, or it is the one and only joint which are free to move in the head and neck region or in the face. So as its name suggests, it's a joint between our temporal bone and the mandible. It is a main joint which connects between this mandible to the joint, and it also allows a huge amount of movement to our face, or basically with our mouth. So we are able to open our mouth, close, and all the chewing activities, all the movements, all the chewing activities has to be done with this temporomandibular joint. The temporomandibular joint is unique within the body, both structurally and functionally. The TM joint is formed by the condyle of the mandible inferiorly and the articular eminence of temporal bone superiorly. This is the mandible bone in our face. So this is the condyles of mandible. We got two mandibles, two condyles. So these two condyles will be getting attached with the temporal bone. So that's how the temporomandibular joints are formed. The lower joint is formed by mandibular condyle and the inferior surface of the disc, and it is a simple hinge joint. The upper joint is formed by articular eminence and the superior surface of disc, and it's a plane or a gliding joint. So because of this intra-articular or the interposed disc, we can divide our temporomandibular joint into two joints, one upper joint and the lower joint. So this interposed disc is actually dividing the temporomandibular joint into two sections, upper joint and the lower joint. So the lower joint is formed by the mandibular condyles and the inferior surface. So this is a normal temporomandibular joint. So here we got two joints, one is upper joint and a lower temporomandibular joint. So this lower temporomandibular joint is formed by the mandibular condyle and the disc. The upper joint is formed by the temporal bone and the interposed disc. The surface are instead covered by a dense collagenous tissue, which is described as a fibrocartilage with a great capacity to remodel in response to physical load. Both articular eminence of temporal bone and the condyle of mandible are convex structures, resulting in incongruent joint. And to reduce this incongruency of joint, there is a disc which mainly to increase the stability and to reduce friction and avoid biomechanical stress to this joint. So that is a function for this disc. So if because of this concavity or convexity of two articulating surface, we should have some structure which can limit the friction and which can improve the movement. So because of this, the interposed disc is actually acting as a structure to reduce the friction, and also it helps to improve mobility. And next is, what are the parts in the mandible? So the mandible got a body and a rami. The point where the ramus and the body meets we called as angle, and in the rami we got an anterior projection called coronoid process. Posterior to this coronoid process, we got a mandibular notch. The mandibular notch is actually anterior to the condyles and posterior to this coronoid process. And we got two condyles and a head of mandible. And this is the temporomandibular joint. It's actually forming in between temporal bone and the mandible. So in a closed mouth position, this coronoid process is actually getting attached with this zygomatic arch. So this is a zygomatic bone. In a closed mouth, this coronoid process is actually placing just below to this zygomatic arch. So whenever we try to open our mouth, this coronoid process are moving away from this zygomatic arch. The mandibular condyles are located at the end of ramen. So these are the two mandibular condyles, and these are formed at the end of mandible in the posterior superior aspect, with each having a medial and lateral pole. So next we are going to discuss about this condyle. So this condyle got two poles, one is lateral and a medial pole. The portion of condyle that can be readily palpated is the lateral pole. So we can actually palpate this lateral pole in our external auditory meatus. We just need to place a finger to our external auditory meatus or into our ear, and we can actually palpate this lateral pole whenever we try to open and close our mouth. So that's how we can actually palpate this lateral pole. Each condyle protrude about 15 to 20 millimeter from the rami. The articulating surface of articular eminence of the temporal bone and the mandibular condyle are covered with dense avascular collagenous tissue that contains some cartilaginous cells. So, as like in normal other all structures or in the normal all joints, this articular surface is also covered by a no vascular articular structure. So next we are going to discuss about what are the properties of this, what is the structure of this temporomandibular joint. That first one is articular surface. The proximal or the stationary segment of the temporomandibular joint is the temporal bone. So in the skull, the lateral side one and the temporal bone possess the superior portion of temporomandibular joint. The condyles of mandible sit in the glenoid fossa of temporal bone. So this is the glenoid fossa, and this is our temporal bone, and this is the glenoid fossa. The condyles of mandibles are actually placed in the glenoid fossa to form temporomandibular joint. The glenoid fossa is located between the posterior glenoid spine and the articular eminence of temporal bone. The glenoid fossa on superficial inspection looks like the articular surface of temporomandibular joint. So that's about the articulating surface. The mandibular condyles are located at the end of ramus and its most posterior superior aspect, with each having a medial and lateral fold. As we said earlier, the mandibular condyles are actually placed in the posterior superior side, and it got a medial and lateral pole. The portion of condyle that can be readily palpated is the lateral pole. This bony landmark lies just in front of the external auditory meatus of the ear. The medial pole is deep and are not able to palpate. Next is articular disc. So as we said earlier, there is a inter disc in between our two surfaces of temporomandibular joint. The articular disc of temporomandibular joint is a biconcave structure, which means both the superior and inferior ends are in a concave shape. The articular disc varies in thickness from 2 mm anteriorly to 3 mm posteriorly and 1 mm in the middle. The disc of temporomandibular joint allows the convex surface of articular eminence and the convex surface of condyle to remain congruent throughout the range of temporomandibular motion. So this is the one of the function this articular interposed disc possesses. Basically, our two articulating surfaces are in a convex shape. So this convex shape articulating surfaces are actually become congruent in the presence of interposed disc. So this, because of this biconcavity of interposed disc, it will give a proper attachment with the temporal bone and the mandible and the condyles of mandible. The anterior and posterior portions of disc are avascular are vascular and innervated. The middle segment, however, is avascular and is not innervated. The disc has a complex set of attachments. The disc appears to be firmly attached to the medial and lateral poles of the condyles of the mandible, but not to the temporomandibular joint capsule medially and laterally. So when we look into the articular disc attachments, the disc is actually firmly attached to the medial and lateral poles of condyle of the mandible, and it is not actually attached to the joint capsule. So this is the interposed disc, and it got an anterior attachment and a posterior attachment. So this anterior attachment, it is getting attached with the superior portion of lateral pterygoid muscle. So this is the lateral pterygoid muscle. So this disc in anteriorly, the disc is getting attached with this superior portion of lateral pterygoid muscle. And when we look into this posterior surface or the posterior part is actually a bilaminar structure. Means it is getting divided in posterior. So when it goes to posterior, it is actually dividing into two. One superior lamina and an inferior lamina. So this superior lamina is actually attaching with this tympanic membrane, and the inferior lamina is attaching with this areolar tissue, or it is attaching with this condyles of mandible. The superior lamina allows the disc to translate anteriorly along with the eminence during mouth opening. So whenever we attempt for mouth opening, this superior lamina is allowing the disc to move forward when we are trying to open our mouth, and the superior lamina is much more elastic than this inferior lamina, and because of this elasticity it will retain its position when we close our mouth. But when it comes to inferior lamina is not as elastic as the superior lamina, and it is actually restricting the movement. The inferior lamina is attached to the neck of condyle and is inelastic. The inferior lamina simply serves as a tether on the disc, and it is limiting forward flexion, and it is not actually assisting in the reposition of disc during mouth closing. So as we said earlier, the superior lamina is much more elastic, and it is the one which is responsible for recoil of this interposed disc. But this inferior lamina is not actually an elastic structure, and because of this inelasticity, it is not actually participating in the function of recoiling of structure when we are closing our mouth. The disc is attached to the joint capsule anteriorly as well as to the tendon of the lateral pterygoid muscle. The anterior attachment restricts the posterior translation of disc. Posteriorly, the disc is attached to a complex structure, the components which are collectively called the bilaminar retrodiscal part. So this is the bilaminar retrodiscal part. So the posterior surface is actually divided into two, superior and inferior lamina, and these are connected with the retrodiscal part. And to be much more precise, the superior lamina is getting attached with this tympanic membrane, and the inferior lamina is attaching with the neck of condyles. And this is what happens during whenever we try to open the mouth. So whenever we are opening our mouth, these condyles are actually going for anterior translation. Along with that, the disc is also going for anterior translation, and during this anterior translation, this superior lamina is actually going for a stretch to allow the disc to move anteriorly. So, and when we try to close our mouth, this because of this elasticity of superior lamina, it actually recoil the position of disc back to normal. So that's about today, and tomorrow we will be discussing about the capsules and ligaments and the function of temporomandibular joint.